So today's topic is on stereotaxis, and I use the, let's see, advancing the slide. Here we go. Here's the outline of the talk. I'm going to review a little bit of the principle and the application of stereotaxis in neuro-oncology. We'll then go into some general considerations and technical caveats in performing stereotactic procedures. We'll talk a little bit about stereotactic needle biopsy, talk about CSF divergence, and therapeutic delivery. Here's a slide that I like to use to illustrate the importance of stereotaxis. Consider the following. It's estimated that there's approximately 100 billion neurons in your brain, making roughly 100 trillion connections. As a frame of reference, there are an estimated 400 billion stars in the galaxy. So we have a galaxy full of neurons concentrated in a volume that's roughly 3.5 cans of Coke. It is incredible to think about the complexity of this, and every millimeter of imprecision in your surgery has catastrophic consequences to these billions and trillions of neurons that defines fundamentally who we are. And stereotaxis is really the way for us to navigate our brain while minimizing injury to these precious connections. The principle of stereotaxis is actually quite simple. It is mapping something that is unknown in a location to something that's known. It's not unlike mapping a cell phone relative to cell phone towers. By knowing what the distance is to each of the towers, if you have 3 towers, you'll know precisely where a cell phone is. And for us, we're touching this 3-dimensional space, stereotaxis, 3-dimensional, taxis, touch. We're touching this space through mapping the unknown to the known. And in the case of the known, for frame-based stereotaxis, it is the frame that we put on. Now, as you know, there are 2 basic methods of stereotaxis. One is to attach a frame to a patient's head, and each of those posts basically serve as a cell phone tower that you can localize your lesion to. By knowing what the distance is of the lesion relative to each of the posts, you know precisely where you need to be. Another way to do this is to map all the anatomic features to a reference frame, which then serves as your fiducial. And you could map out, again, the lesion distance to these 3 spheres, or 4, depending on what system you use. You'll notice that I purposely show BrainLab and Medtronic, and just so that we don't have a commercial bias in terms of the images. There is yet another a system that I'm going to talk about and refer to, and this is a frame that's developed by ClearPoint. And essentially what this is that, let me get the laser pointer back on. You can see that this is a frame that you can mount onto the patient's head. And on this frame, there's 3 fiducials that are filled with contrast enhancing material. So on the MRI, then, you can map where your lesion is based on these 3 fiducials. And the benefit of this system is you could make your trajectory, adjust your trajectory in real time, depending on what you see. And I'll demonstrate the utility of this in challenging biopsies. So in terms of application, here are the things that I'm going to talk about. In neuro-oncology, the fundamental purpose of stereotactic surgery is to achieve definitive diagnosis for lesions that are not easily accessible. Through tissue diagnosis, we'll identify the tumor grade histology that essentially serves as the foundation for modern management of intracranial lesions. More and more, we're using genomic analysis of the samples as well to guide therapy. Although in neuro-oncology, this option remains somewhat limited in terms of, and it's limited more by the amount of the number of therapies that can cross the blood-brain barrier. As we embark into clinical trials, sample acquisition for biomarker analysis and vaccine preparation it has also emerged as a practical use of stereotactic biopsies. Stereotaxis extends beyond just biopsies. In many oncology patients who suffer from tumors or from scarring due to surgery or radiation, patients develop trapped CSF compartments. And we can use Stereotaxis to thoughtfully treat and mitigate the symptoms related to these trapped CSF collections. And we'll talk a little bit about that. And most recently, the development of laser ablation, as well as oncolytic viruses, has offered us an opportunity to use stereotactic means to precisely deliver and administer these therapies for the benefit of our patients. So I'll talk about each of these in this presentation. First, a couple of words about general considerations, and these are really, the next few slides are meant for residents. For the first consideration is that there are many different types of stereotactic frames in terms of frame-based, and similarly, there are different types of systems for frameless. The first comment I would make to the residents is that if you're not familiar with the system, make sure you familiarize yourself with it the night before surgery. I've seen some pretty creative ways of putting the frame together that introduces air, while these systems are really engineered to fit together really in one way only. It is possible to put the frame, assemble it incorrectly. So that's the very first point. The frame fundamentally defines your three-dimensional space, and if you have put the frame together in a way that is not designed in a way that's not correct, then your stereotaxis will be off. The second thing is to consider is CSF aggression. Now, brain shifts in open craniotomy is well appreciated. Every one of us have seen what a brain looks like at the beginning of the case and what it looks like at the end of a case. And typically you'll see some form of a shift. What's less appreciated is that brain shifts can actually occur just by making a burr hole. This is a study by Dr. Larson at UCSF, and I thought it was a brilliant article that looks at various neuroanatomies before and after a burr hole procedure for DBS. And what's notable here is that while the average shift here is really minimal, you can see that the mean shift is less than 1 millimeter. In some situations, cerebral anatomy could shift by as much as a centimeter, basically, as you can see from this study. So it makes sense when you're doing a challenging biopsy. Now, I should backtrack. If you are biopsying a large lesion, 2 to 3 centimeters, a shift of 5 millimeters is not a big deal. You'll still end up where you probably want to be. But if your lesion is 3 millimeters or 4, these shifts can fundamentally result in missing the lesion altogether. So if you're doing a challenging biopsy, it's worthwhile considering using a smaller twist drill and or to plug the brain exposed and prevent CSF aggression. Skiving. This is something we've all experienced. If you're making your burr hole and you're not completely perpendicular to your entry point, you could deviate your burr hole such that it results in complete translation of your intended axis. Here's an interesting case that really made me realize how important skiving is. This is a patient who has a supracellular lesion. Let me go back to the laser pointer. You can see that has progressively enlarged, and as a result, the patient suffered a visual field deficit. We wanted to get tissue diagnosis so that we could treat this accordingly. So what we ended up doing, this is a surgery that I was doing in the MRI. After drilling the burr hole, we inserted a ceramic stylet partially, and we calculated if we were to continue that trajectory, can we get to the lesion precisely? And what we see here is that when we did that, we realized we were off by about 3 to 4 millimeters. And when we looked at, in retrospect, when we matched the brain anatomy, it didn't look like the center of the brain had shifted. It wasn't a shift issue. So in this particular case, what we ended up doing is we drilled our burr hole and retargeted, and we were able to successfully achieve a biopsy here. And you can see in this situation, if we were spot on, the blue circle and the orange circle should overlap. And so this is what we're able to achieve after we re-drill the burr hole. And so this is a case of a intracranial histiocytosis. The patient underwent chemotherapy, and you could see that her vision was restored and the lesion had shrunk accordingly.